And with that, we move to the last talk of this session from Dr. Nguyen, who is a professor at Stanford University. He's a Yale graduate, as I can tell from the insignia at the back. I think you're hiding somewhere the Phillips Academy. Oh, sorry, the Exeter, I meant, insignia. And so he's going to talk on the safety of intravenous high-dose PulseMethylprednisolone Succinate in the management of pediatric uveitis.
Thank you for the warm hospitality in having me at this unique 11th Pan-Hellenic Congress of Ocular Inflammations and Infections. Once again, I would like to express my deepest gratitude to Dr. Sophia and Trudy and the organizing committee for the very kind invitation. I apologize that I could not join you in person as our university still has restrictions on traveling. Today, I would like to discuss with you about intravenous high-dose methylprednisolone in the management of pediatric uveitis. My disclosure are listed here. Let us begin with this case, his presentation. The patient was a 14-year-old female who was referred to our uveitis clinic for unilateral severe iridocyclitis. She has been treated for 6 months with short-term oral steroid and frequent topical steroid. She developed ocular hypertension and likely was a steroid responder. Her medication at the time of presentation to us was prednisone acetate and topical anti-glaucoma medications. The patient has no history of associated systemic disease, review of system was non-revealing, and laboratory evaluation were negative for infectious and non-infectious agents. On clinical examination, the patient showed a visual acuity of 20/20 in the right eye and 20/30 in the left eye. The cornea was clear in the right eye and demonstrates presence of keratoprecipitates in the left eye. The anterior chamber was quiet in the right eye and showed one blood cell and one blood flare in the left eye. In addition, there were posterior synechiae of the left iris. Intraocular pressure was 12 on the right and 28 in the left, and the anterior vitreous showed retrolental cellular infiltrates in the left eye. Fundus examinations revealed a clear vitreous and mia on the right eye with normal optic nerve, macular, vessel, and periphery. In the left eye, there was 1+ vitreous haze and cellular debris showed. In addition, there were hyperemia of the optic nerve and sheathing of various vessels. There were no frank chorioretinal lesions seen. Fluorescein angiography of the right eye showed normal vasculature. Fluorescein angiography of the left eye showed early evidence of optic nerve and perivascular leakage, which were quite significant with the later phase. Based on the clinical findings as well as the finding on fluorescein angiography, a diagnosis of unilateral chronic panuveitis with severe vasculitis was made. At this time, what may be our treatment option? Certainly local steroid is not appropriate because the patient is a steroid responder. In addition, local steroid would most likely not able to address the posterior segment disease. Oral corticosteroid could be considered, but the patient has used it previously and did not achieve complete quiescence by the findings that we just observed. The use of immunomodulatory therapy certainly is possible, However, given the very active disease and the retinal vasculitis, our concern was that non-biologics immunomodulatory therapy may have slow onset of action. Consideration for various biologics was certainly possible. However, there was difficulty with the insurance that was approving her to receive such treatment, despite the fact that one of the TNF inhibitor, adalimumab, has been approved for the treatment of uveitis. Thus, do we have any other options? At this time, we highly consider the use of high-dose intravenous post-steroids. Post-steroids have been found to be effective in a number of our patients previously. We have had good results in managing uveitis with high post-steroid in adult. They're more convenient because we usually only give 1 to 3 days per month. Our experience indicated that there were less complication and adverse event than oral formulary of corticosteroid, and that post-steroid can be quite effective. What about in the pediatric patients? Searching through the literature, we noticed that post-intravenous corticosteroid has been used in lupus nephritis as well as in Kawasaki disease. Doses up to 30 milligrams per kilogram, and which may be repeated, has been used and published. Therefore, in this case, we decided to treat the patient with intravenous infusion of methylprednisolone at a dose of 10 milligrams per kilogram per day for 3 consecutive days per month, and then treat it for 6 months. Let us share with you the result that we have seen. At presentation, one recalled that there were presence of vitreous haze, optic disc hyperemia, as well as vitreous debris and cellular reaction. After 2 months of treatment, they already demonstrate good response in tumor reduction in haze and reduction in disc hyperemia. Such improvement continued to 4 months, and subsequently 2 months after the infusion was stopped, the fundus of the right eye remained clear, and certainly the fundus of the left eye have shown much resolution of the disease processes that was seen initially. Fluorescein angiography also showed remarkable improvement. We caught the presence of optic disc inflammation along with perivascular leakage at presentation, which then show improvement after 2 months, after 4 months, and show complete resolution 2 months after stopping the infusions of intravenous methylprednisolone. What about the safety? Certainly, whenever one administers high-dose corticosteroid, one always needs to be concerned about the safety for the patients. In this particular case, we did not see any elevation in blood sugar. There was no elevation in blood pressure, no weight gain, no cataract, and no concern with growth retardation given the age of the patients. Please also recall that in this case, intravenous methylprednisolone was given alone without any other biologics administration. The patient continued to do well 4 months after stopping the post-corticosteroids with no notable adverse events. Visual acuity have improved now to 20/20 in the left eye, and we have started the patient on oral methotrexate as a mechanism to control disease and to maintain it in the disease-free status. Given the success of our case, one can ask, are there additional data to support our clinical application of the use of high-dose intravenous methylprednisolone in pediatric uveitis? I'll illustrate in this index case. In the literature, currently there's a lack of published data on intravenous high-dose post-methylprednisolone in the management of severe or refractory pediatric non-infectious uveitis. Because there's no clear data that has been published, we decide to proceed with looking at our overall result to evaluate the safety of intravenous methylprednisolone in refractory and severe pediatric uveitis. Our purpose was to evaluate the safety of intravenous high-dose post-methylprednisolone in the management of severe or refractory pediatric non-infectious uveitis. We reviewed all uveitis patients who had been evaluated in our service who were 16 years of age or less and who received intravenous high-dose methylprednisolone with a dose of equal to or greater than 500 milligrams per day, 1 to 3 days a month, for at least 3 months during the management at a tertiary care eye hospital. That was the Byers Eye Institute at Stanford. Let's look at some of our preliminary results. We noticed that there have been approximately 20 pediatric patients with severe or refractory uveitis who received intravenous high-dose methylprednisolone during the past 4 years. 6 patients received a high-dose intravenous methylprednisolone either once as a preoperative medication or at a lower dose than 500 milligrams and were excluded. The remaining 14 patients received intravenous high-dose methylprednisolone for at least 4 months and were thus included in this study. The age range was about 12 years of age, and the 50% were female. The duration of treatment was approximately 14 months. 13 patients received intravenous high-dose methylprednisolone in combination with other immunomodulatory therapy. Except for 2 outliers, the dose of high-dose intravenous methylprednisolone was at 8 to 25 milligrams per kilogram per infusions. First, let us concentrate on the safeties. There were 3 major adverse events that occurred in 2 out of the 14 patients. There was a single episode of bradycardia. There was 1 case of compression fracture following minor trauma in a patient who also had adrenal insufficiencies. We noted that the number of adverse events, both major and minor, strongly correlated with duration of treatment and modestly correlated with cumulative dose. In addition, we noted that the weight gain was associated with the use of concomitant oral corticosteroids at a low dose, and even at a low dose, and not with duration of treatment or cumulative doses. Thus, based on the study of our own populations that we have treated thus far, we concluded that intravenous high-dose post-methylprednisolone may be an appropriate treatment option for aggressive and refractory pediatric uveitis. The reported adverse event in our series may also be attributed to the concurrent immunomodulatory therapy or to the underlying disease itself. Therefore, in conclusion, what I hope to share with you today, based on our experience in managing pediatric non-infectious uveitis that were either severe or resistant or refractory or show incomplete response to other treatment modality, including immunomodulatory therapy and use of biologics, is that intravenous post-steroid may be a safe and effective therapeutic option in the management of severe uveitis in selective pediatric population. Certainly, one should consider carefully each patient and to assess the overall risk and benefit before we begin any therapy, including intravenous post-steroids, such as that with methylprednisolone. Thank you again for the very kind invitation. I look forward to meeting you in person and discussing with you how we can manage our patient better. I appreciate very much the opportunity to be with you, although virtually, at this wonderful Congress. Thank you again.
Thank you, Nguyen, for this excellent talk. I learned a lot. This was very nice. I noticed at your study that you had some patients that you kept long for on pulse steroids, something like 20 months or so. So moving on to other treatment options like IMT was not an option for them. I mean, how long do you think it's safe to keep a child on pulse steroid? I mean, how long would you keep safe? Is there a cutoff, like, let's say 6 months, a year? And why didn't you move on to other treatment options in your patients that you kept on long?
Yeah, that's certainly a very real important concern. In general, we do not like to keep our patient long-term on steroid. That's the whole principle of treatment with this aspect. And these are the patients who otherwise did not respond well. For example, when we try to add a oral IMT, whether with mycophenolate or with azathioprine or combination with not, we were not able to maintain them well. So then we need to then rely to them on perhaps we can add a biologics to do this aspect. And in this cases, adding a biologic to them by itself did not help. So then we had to go back in to add this corticosteroid. So I would like to make it clear that we do not, and I repeat, we do not advocate using intravenous steroid or oral corticosteroid as the main treatment for this, because we know that always lead to trouble. It is only in cases where we do not see respond, or we have trouble getting other treatment, or they don't respond well, then we can consider this. And my concern is that I am worrying about the use of oral daily prednisone, because those are not good. Those often lead to significant trouble. So I was trying to think whether or not IV steroid can do the trick without much of a side effect to them. And this is what we have learned. So for those patients who need to be on this, we can provide to them somewhat a little bit longer term, but make sure that we don't at the same time have even low dose oral corticosteroid alone, because that I think is a potential risk factor for developing a lot of problems later on. So again, Sophia, as you imply, I and we should not advocate the use of corticosteroid as a first-line therapy.
Okay, thank you. Are there any questions from the?
I have to congratulate and to thank Professor Nguyen. I had 2 questions, but during your lecture, I had answers in both of them. And even after that, I have a 3rd question, but your answer in the question of Sophia covered me. Thank you, Didi.
Thank you, everyone. It was great seeing you, even virtually, and you looking forward to have you in person in the future meetings. Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you. Bye-bye.
Συνεχίζουμε, ευχαριστούμε.